I have personally done it, although I'm not supposed to be doing it and spending time on it. So now
Thank you,
nobody
sir.
can say it has not gone.
Thank
Yeah,
you.
it has gone. They have to, I mean, it goes with something like zoom.us or something.
Yes, yes.
99% it will be sitting in their spam. So we have 63 people. It's 3:35. Would you
Mansi,
like to
you
wait
also
for another
informed
5
your
minutes?
Yes, I will also inform.
Yeah, should I wait? We wait for another 5 minutes before we begin, or how do you want to do it?
We are
We
already
will wait
5
for
minutes
5
late.
minutes.
Yeah, I know.
Hmm.
But, typically we fully understand that, everybody is running around doing multiple things, so we do give a grace of 5 to 10 minutes before we actually commence the program, all of them that we have had so far. So it's absolutely acceptable. So not an issue. And today we are not under too much stress because there is no RAC or DHRA program which is following you all. If you're 3:30 to 5:30, we give a grace of half an hour for RAC. So 6 o'clock. So there's no program at 6, any other program on this Zoom link. So we are safe that way. Otherwise, we have to step in and say, request, can we close the session soon? I don't know if this mail has gone to PC or.
Yes, sir. Yes, sir. I have informed, sir.
Okay.
But he will be busy. He has told if possible, he will join.
Oh, okay. I'm so looking forward to meeting him online. I haven't met him for the last few years now.
Okay.
Can we give the recording also and they can be the master trainer? Is it possible, Mr. Ajay?
No, master training sessions are over now. We are not adding any more to the master list. We have already got 700 people, master trainers from across.
Yeah.
So we don't need any more master trainers. What we need is the existing set of master trainers to roll out the program either in their societies, or if the societies is not pushing the program, then we involve these master trainers in other societies who may want to have you. So what we do is once a society shares a program with us that they would like to do it on an XYZ date from so-and-so time to so-and-so time, we ask the society, just as we asked you all, do you want to have your own trainers or you want us to allocate? And in case the society tells us, no, you allocate, then what we do is we send your date and your time to all the 700 people. Okay. And request them to volunteer. And it's first come, first serve. So whoever checks the mail and immediately corresponds saying that, okay, I would like to take the session, we allot the session to them after doing a background check in terms of, whether the person is actually a master trainer, has completed the course, has been given the certificate, or will be given the certificate. So all that back end, checks and balances are done. And then, the core team sits down and immediately looks at the names which have come forward. So we look at 3-4 names for one topic. And out of those topics is the national faculty core group, about 25 of us are there, looks at the names. So if we will see, if Sasmita and Richa both have said that they will take the MTP session, how many such MTP sessions have they taken in the past for this program? If not, what is their experience in conducting a similar? So, there is a little bit of, because I think on 25th, we have a program where we have 500 registrations. Okay. Now 500 senior, junior, mid-level people will be sitting. So we want somebody who has the, the capacity and the experience to be able to handle such a big crowd, including the question answer sessions which come in, so that there is a successful program. So you see, that's where the whole thing is balanced out, so that we come out strong as a team, and everybody stands to benefit from the program that has been conducted. So I hope that answers a lot of your questions.
Yeah. So today's participants, they will get participation certificate, no, not the master trainer.
They'll be the champion RACs.
Okay.
RAC champions. And all the master trainers have already perhaps got this certificate or in the process as master trainer certificate. Yes.
Now we can start.
It is interesting that you all ask about master training. It always amazes me that when we announce the master training sessions, we get multiple requests and multiple registration. So I can tell you from my own experience of now we have done about 9 master training sessions, 3 more than what we have planned to do and what was allocated by the funder. Every master training session we have got, suppose, for example, we have got 100 registrations. On the day, only 60% have showed up.
Yeah, that is true.
And what happens is once the session is over, these 40 who have not joined, there will be a barrage of mails and barrage of WhatsApp messages. Sir, we couldn't do it. Ma'am, we couldn't do it. Then they will call up Shanta. They will call me up. They will call Kiran Mai. They will call Madhuri. They will call Krishnan. I mean, they will call everybody who's possible. No, I want to be in the, but there's no other session now. What can we do? You know.
already we have sufficient.
Yeah, we are already 5 minutes late.
Yes.
Dr. Sasmita, Tushar Shah is joining.
Rather, we should go to the topic.
Sir will
Yeah, I
join.
think so. We
It will
should
be better
start.
if we
I
go to the
agree
topic.
with you because
Yes,
you know, otherwise
we should
we'll
not
be
bother about the
chatting on
number.
all of
We
this.
should bother about the quality. Those
Yes.
people who are interested, they are joining. So why
Yes.
you will wait for the numbers only?
I will fully agree with you. It's just giving an opportunity. You know, suppose you are stuck somewhere and you really wanted to join. It's just giving you people like yourself or similar like you an opportunity to be able to join. And it is nothing to say that, you know, wasting your time or your time is equally precious as mine and as everybody who's sitting over here.
So let
And
us start.
I'm sure you would do something better in this time than just waiting. I think we can start now because almost 10 minutes
Yes, sir.
have given grace and we should not wait for any further
Yes.
on this
Thank
bit.
you. Thank you. Sir.
Yeah.
Please go ahead.
Yes, sir.
So good afternoon, everyone. It's such a pleasure to see each one of you here and for arranging this program under the aegis of the Obsgynae Society of Odisha. And I'm delighted to be here. This is a flagship program, yet another flagship program of our beloved President, Dr. Shanta Kumari, who has partnered with WHO, the India office, and has initiated this entire program for our country and for our fellow obstetricians and gynecologists. It's important milestone for us over here today because in the 19th, India actually has been amongst the first countries, among the first few countries to have initiated, you know, something related to medical abortion and laws and rules related to as early as 1970, when it was, you know, called something, it was called as unsafe abortion. It almost took us 30 years, that is in almost 2000, when it was called safe abortion. And it has taken another 20 years for us to now realize that it is not just unsafe abortion or safe abortion, it should be respectful abortion care. So it's almost after 50 years that we are arrived at the situation where we say that we are talking about respectful abortion care. In terms of numbers, I'm sure the slides will be talking much about it as we go along. But almost when we talk of it, that, you know, it's the third leading cause of maternal mortality in our country, and perhaps morbidity related to this particular issue, and which needs to be taken care of. And still in many parts of our country, the abortion care either is not given or not you know, given in the quality that is expected, or given by an individual who is capacity built to be providing such a service to the women of a country who require it, who need it, who want it, as we kind of go forward. So with those few words, thank you very much for having me here. And I would also like to talk on two operational bits over here. The first operational bit is related to the post-test and feedback, which will be posted in the chat box for each one of you to click on the link and submit the same. For those who miss out the chat box and not able to submit it through the chat box, when you leave the meeting, that means when you click on the button leave, you will get a pop-up, and that pop-up will say continue to submit survey. Please click on the continue button so that you will again be taken there. So those who submit through the chat box, do not redo it because it's submitted. Those who miss out from the chat box can do it again and submit that. Even after you miss that, there will be a third opportunity which will be given to you, whereby we will send an email to you for all those, only for all those who have missed out, this particular link through which you can submit the post test. Today we'll be covering 4 topics. One will be on the MTP itself, Amendments 2021. The second would be safe abortion and the technologies related to. Many of you are already practicing it, so that they may be not something new. It's just a reiteration of everything that we have spoken about. The third topic will be the WHO Saver module and the toolkit. And the fourth topic would be, which we'll be covering today, would be pre and post counseling, which plays such an important part in terms of the respectful abortion care that we are talking about. With those words, thank you very much. I hand over to the MC for this session to take over and walk us through the next sets of things and the process itself. All the very best, each one of you, each of the faculty who has joined. And thank you.
Thank you so much, sir. Now we would like to start with the RAC program today, WHO RAC program, which is being organized by FOXY and AOG Odisha. For the formal starting of the program, I would like to request our AOGO Secretary, Dr. Sasmita Swain, Madam, Unit Head and Professor of SCB Medical College, to Madam say a few words and start the program formally.
So good afternoon, everybody.
The direction is around MTG.
So I welcome everybody to this unique training session of RAC conducted by the collaboration of World Health Organization and FOXY. So I am so happy that Ajay sir has joined us as a national faculty, and I am also very happy Dr. Richa Sharma has joined us, the MTP committee chairperson. Welcome you, Richa madam and Ajay sir. And Dr. Tushar sir is waiting. He is not able to get the link. We are again sending the link. He will be joined. Our president, Dr. Tushar sir, will join us. So actually a few months back, a message come from FOXY that you select few members from our society for the master trainer for the RAC program. We send it and we got the training. And after the training, they gave us the responsibility to spread this message throughout our society. So all the members will be enlightened about this new amendment, and we will spread the respectful abortion care among all our members, so that no woman who comes to us for abortion will at any point of time will feel disrespected, neglected, or alone. So it is our responsibility as the healthcare provider to see that all the women get their importance and they never feel neglected. So this is the aim of the program today. So with this, I will request Richa madam, and Kit madam has joined, Barsa?
Madam, just checking.
So it is our pleasure.
Yes, madam. Kirti madam has joined us.
Tushar sir, phone करते हैं? Sir,
पूरा mute है एक बार.
हाँ.
Sasmita have joined. Okay, madam.
Sasmita have joined. Everybody.
So I think I should start the first session. And today chairperson is Dr. Richa Sharma and Kirtireka Mahapatra. Kirti madam is our professor in SCB Medical College. She is a very good teacher and she has lots of interest in obstetrics, high-risk pregnancy, and she will be conducting the next session. So with this, I will start my first topic today. That is the share screen. So first I will request Dr. Richa Sharma to tell few words to us.
Good afternoon. Can you hear me? Am I audible?
Yes.
Yes.
Yes,
Good afternoon, everybody. And first of all, I thank Dr. Tushar sir and Dr. Sasmita Swain and the team Yogo for inviting me here. And I think today's webinar is very important because we need to keep ourselves updated. And medical termination of pregnancy, it involves something like the procedure is so small, but then it has so many serious medical legal implications. And other thing is that, as Dr. Ajay sir has already mentioned, unsafe abortion, it is a third leading cause of maternal mortality in our country. And almost if you see 10 women they die of unsafe abortion every day, and 1,000 women, they suffer from serious complications of unsafe abortion every day. So I thank Dr. Shanta Kumari ma'am also for initiating this wonderful project, and so that we can teach our doctors again and again, and so that no woman should die of unsafe abortion in our country. So thank you, Dr. Shanta ma'am and Dr. Ajay sir also, and the team Yogo. So now with that, I hand over to Dr. Kritika to introduce Dr. Sasmita. She's the first speaker.
Good afternoon, one and all. I must, at the outset, I thank the organizers to give me a chance to chair here in such an interesting and important training program. Our first speaker, Dr. Sasmita Swain. She is a professor of our SC Medical College, and she is very good in organizing capacity, and our secretary AOGO, and she is a very nice teacher, and everyone over here must be knowing her. This doesn't need much of introduction, and she will be talking on medical termination of pregnancy amendment 2021. It is very important. Some changes has come, and everyone should be updated with those changes, where one can do, which are the methods and what to do. She will be telling detail about it. Sasmita, madam, please.
Yes, thank you, Kirti madam, for your nice introduction. So now I will be speaking about the medical termination of pregnancy, the Mtp Amendment 2021, and the respectful abortion care. It is a joint venture of FOXI and WHO initiative.
Slightly visible.
Is my slides visible?
Yeah,
Yes,
your
yes.
slides are visible.
Quite visible.
Yeah.
Please change your slide.
Jauni, कौन करेगी? Photo में जी.
Yeah.
So
Yes,
the
yes.
objective of this is we will take a closer look at what are the new laws and what are the changes in the rules. So this is the thing we'll discuss now. So unsafe abortion in India lead to mortality, morbidity, and hampers women's and girls' full participation in this. And it has been seen that 80% of maternal death per year occurs due to abortion. And this is a third leading cause of maternal mortality rate. And nearly 2 out of 3 abortions performed are deemed to be unsafe. And nearly, most very pathetic, nearly half of the pregnancy-related deaths occurs in women or girls under 25 years. So what is when we consider an abortion to be unsafe or safe? So according to the WHO definition, to say that the abortion is safe, it has to be done by appropriate methods and by trained persons. So if there is lacking of anyone, it becomes less safe or unsafe. So to be abortion to be safe, it should be done by appropriate methods. So we all should know what are the appropriate methods in our next talk. And also it should be done by the trained persons. And we must be aware who are the trained persons eligible to do the abortions. So medical termination pregnancy amendment, which is safe and comprehensive care mandated by law. This amendment has been done in the September 2021, and we'll now discuss what was the previous one and what is the present one, what change has been done and why it has been done. So what are the salient features of this? So there is modification in requirement of provider. Previously, we require one opinion for MTP up to 12 weeks, and up to from 12 to 20 weeks, 2 opinion of the doctors were required. But now this has been changed. There is a requirement of opinion of 1 registered medical practitioner or RMP for termination of pregnancy up to 20 weeks of gestation. And after 20 weeks, the upper age limit of abortion has been increased up to 24 weeks. From 20 to 24 weeks, we require 2 RMPs. Why this has been done? Because in many public facilities, there is a single doctor who cannot perform an abortion beyond 12 weeks. So patient has to come to another hospital for that. So to increase the number of facilities, especially in public sector like PSC, this provision has been provided in the new amendment. So modification for vulnerable group of women. Previously, the MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. Beyond 20 weeks, if the life of the mother was in danger, then only it was provided that too under the law. Permission from the court was required for that. But now in 2021 amendment, this has been, the upper limit has been enhanced up to 24 weeks for special or vulnerable categories of women. That we have to understood that the upper limit from 20 to 24 is applicable only for special or the vulnerable categories of women. And we will discuss later who are these vulnerable groups, who, in which case we can do the MTP up to 24 weeks. And further enhancement of birth defects not causing life or medical beyond that, which the birth defects which is not compatible with life or will have very bad consequences. In those cases, we need medical board consensus. फोटो गुड़ा केम जियो बंद कर दीजिए वीडियो ए फोटो गुड़ा केम जियो So the potential, what is the outcome? So there is increased access for vulnerable women to safe and legal abortions defined by rules committee includes, and what are those vulnerable groups? This includes the violence victims, minors among others, and also other 7 groups of people are included in this vulnerable group, which we'll discuss. Nine.
Sasmita, slides are not moving.
Oh. एट में ले जाओ हाँ हाँ गल So there is a modification for birth defects and congenital anomalies. Previously, the Act had the provision for termination of pregnancies only up to 20 weeks. But that beyond 20 weeks, you have to take the permission from the law. But the upper gestation limit does not apply in case of pregnancies with substantial fetal anomalies, and it has to be made by the medical board. So if we diagnose any fetal abnormalities, and which is not compatible with life, or if even if it is compatible, it will have severe morbidity, then it can be conducted by a medical board. So what is the outcome? There is increase in access to safe and legal abortion services, who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late. Because nowadays, due to the very good ultrasonography, we can diagnose many fetal abnormalities which appear late in the pregnancy. So for that, previously we did not have the permission to conduct the abortion. But with this increasing the upper limit, in those cases, now they can come and access the facility. So there is a huge modification related to marital status. Previously, the condition of failure of contraceptive was applicable for only married women or her husband. It was the contraception failure, which we usually use many times, indication contraception failure. And it was applicable only in cases of married woman or his or her husband. But now that condition has been over. So condition of failure of contraceptive has been extended for any woman or her partner, irrespective of her marital status. So any unmarried girl, if she comes for abortion, we have to do it, and we should respectfully do it. So what is the potential outcome? There is increased access to safe and legal abortion for any woman, irrespective of marriage age. Because this was a very good, because of the lifestyle changes, because of the change in the socio-cultural of life. So many unmarried girls, they are shy to come to us because they are not confident that we'll maintain their dignity, their confidentiality, and so they may go for unsafe abortion. So to prevent that, the marital status has been taken off from the, the previous was there, it has been abolished. So irrespective of marriage, if she comes, we have to conduct the abortion respectfully. So now the insertion of new clause for strengthening privacy. So now the privacy, name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So it is mandatory by law that we should not disclose the name or other particulars of a woman who has come to us for seeking abortion. At any time we cannot disclose their particulars or name to other persons unless it is required by law. So what is the outcome? So increase in privacy and confidentiality of abortion seekers. So that will increase the demand. So if we will maintain the privacy and maintain the confidentiality of abortion seekers, then there will be increase in demand, and we have to safeguard the rights and dignity of women and provide respectful, bias-free services, including counseling and contraception. That is also very important. Once you have done the abortion, we have to counsel them. We have to educate them regarding contraception and its advantages. So that part also we have to look, and this is also included in the law. So the law prioritizes confidentiality and safety. So name and other particulars of any woman seeking abortion has to be confidential except to a person authorized in any law for the time being in force. And the ground of failure of contraceptive has been extended to women and her partner irrespective of her marital life. So what are the rules under the Mtp Amendment of 2021? So it defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. So till 20 weeks, we can terminate any pregnancy, but beyond 20 weeks, up to 24 weeks, this can be done only in vulnerable category of women. And the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestation age has been defined. And the powers and functions of the medical boards, the OBG specialist, the pediatrician, plus radiologist when available, they form in the medical board, and it has to be formed in every state, and it is mandated to provide timely evidence-based decisions regarding these cases. So now we'll discuss who are those special category women who are eligible for MTP between 20 and 24 weeks. So there are 7 categories. So what are those? They are survivors of sexual assault or rape or incest, women with pregnancy in humanitarian settings, disaster and or emergency situations as declared by the government. Because due to some disaster, if the woman is not able to reach the health facility in time, and she has come late, we cannot deny her abortion. We have to do it even if it has crossed 20 weeks. Similarly, change of marital status during the ongoing pregnancy. If during the ongoing pregnancy, the woman becomes widow or there is divorce and she does not want to continue the pregnancy, then we can, even if it is beyond 20 weeks, but within 24 weeks, we have to terminate. Similarly, women with physical disabilities, major disability as per criteria under the Disability Act can opt for abortion between 20 to 24 weeks. Mentally ill women, including mentally retardation, minors, and most important, with the advent of the very good ultrasonologists and the ultrasound machines, fetal malformation has been diagnosed very late. So in those cases also, we have to go for termination in late pregnancy, and it has no upper limit. One important thing, it has no upper limit. If the medical board decides that this fetus has to be terminated, then this pregnancy has to be terminated. So irrespective of the upper limit of the gestational age, we can do this. So the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped, has included in the vulnerable group. Coming to the norms for the RMP, registered medical practitioner. So RMP defined in the old act was MBBS or more with any. So what are those? So medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in a hospital. Or medical practitioner who has completed 6 months of house surgeon in obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. And medical practitioner who has experience of at least 1 year in the practice of OBG. So up to 20 weeks, this is one amendment, very important amendment. Up to 20 weeks, one RMP opinion is sufficient. 20 to 24 weeks, they have to belong to the vulnerable group, and for that we require 2 RMP opinions. And beyond 24 weeks, we have to go for medical board opinion, and if they have the power to conduct the abortion, or they can deny the abortion according to the decision of the medical board. Under the, this is a new rule, under the amendment rules 2021, an additional category of provider has been added for termination up to 9 weeks with medical method, that is MMA. So for that, the experience or the has been reduced to 3 months. So RMP with experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by MMA under supervision of RMP in a hospital established or maintained or training institute approved for this purpose by the government. So if the registered medical practitioner has the experience of 3 months and has a training or has a training in conducting MTP MMA in 10 cases under supervision, then he is able to do termination up to 9 weeks. So up to 9 weeks, we require the 3 months of experience, which was previously 6 months, it is 3 months. So the norms for the RMP whose opinion is required for termination of pregnancy at different gestational ages. So till 9 weeks, 5 criteria, 5 RMP categories of RMP can conduct the termination. Who are they? So experience at any hospital for 3 months in the practice, or has assisted in 10 cases under supervision, or he has assisted RMP in the performance 25 cases of MTP, of which at least 5 have been done independently, a practitioner with postgraduate degree or diploma in OBG, or a practitioner having 6 months of house surgeon in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So opinion of 1 RMP is required, and 5 categories of RMP can conduct the termination till 9 weeks. So beyond 9 weeks, the first one will be cut off. And even in this till 9 weeks, we have to maintain the confidentiality of the patient. We cannot disclose to other persons about her termination or abortion. So till 12 weeks, we require 1 RMP, but the first one, the 3 months experience and assisting 5, this has been deleted. They cannot do beyond 9 weeks. For till 12 weeks, we require 1 RMP is required, and these are the criteria. Those who have assisted in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital, and a postgraduate or diploma in obstetrics and gynecology, or a practitioner who has completed 6 months of house surgeon in obstetrics and gynecology, or those practitioners who has 1 year of practice in OBG. So they can do up to 12 weeks. So beyond 12 weeks till 20 weeks, experience and training requirement is 1 RMP. Up to 20 weeks, it is 1 RMP. But the practitioner must be a postgraduate or a diploma in obstetrics and gynecology, or a practitioner who has completed 6 months of house surgency in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So it has been reduced to 3 categories of beyond 12 weeks till 20 weeks. Opinion of 1 RMP is required, and they have to belong to these 3 categories. So now comes beyond 20 weeks till 22 weeks. So the experience and training requirement of for RMP. Here, beyond 20 weeks till 24 weeks, you require opinion of 2 RMPs. And they have to be a postgraduate or diploma in obstetrics, or they have at least 6 months of experience in obstetrics, or they have 1 year experience in any hospital for a period of 1 year in the obstetrics and gynecology. So here we require 2 RMPs opinion beyond 20 weeks. Next comes what happens beyond 24 weeks. So here the law has become very patient friendly. You can go for beyond 24 weeks, but here we need the opinion of medical board is required. For the termination of procedure, when advised by the medical board, it is carried out with all safety precautions along with appropriate counseling and at an approved place. So who will do this? A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And the medical board will advise where to do it and how to do it. So what is the medical board? This is very important, and at present in our country there are around 180 medical boards are there. Every state has a medical board, and if required beyond 24 weeks, if it needs, we have to go for the medical board advice. So the medical board is comprised of a gynecologist, a pediatrician, and a radiologist or sonologist if available. What is the power of the medical board? The power of the medical board is to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration, and ensure that the procedure will be safe for the woman at that gestation phase, and whether the fetal malformation has substantial risk of it being compatible with life, or if the child when born would suffer from such physical and mental abnormalities to be seriously handicapped. So they will decide what to do, whether to terminate or to continue. And whenever required, they can co-opt for other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. So they, if required, suppose they had disease, they can opt for a cardiologist, or if there is any neurological problem, they can opt for a neurologist also. They can take in their board. And what is their function? To examine the woman and her reports who would approach for medical termination of pregnancy, to provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical. So they have to be very prompt, because it is beyond 24 weeks. The more we make the delay, the more complications can appear. So we have to take early decisions. They have to give the report within 3 days of receiving the request. And to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of receipt of the request for medical termination of pregnancy. This is also very important. And FOXI has an important role to play in ensuring there are functional medical board in every state, as is stated in the Mtp Amendment 2021. Already the Government of India has sent instruction to the NHM in the state to forms medical board in every state. So at the conclusion, we all must be we all must know the new act and practice this new act. And in India, we are proud to say that in India, abortion is legal, and India is leading globally in this abortion amendment. And it is our duty as a function, as a service provider, we have to make it safe and we have to make it respectful. Thank you. Hello?
Yes, ma'am.
Barsa, with this, I conclude my topic. If there is any question.
Good evening, ma'am. This is Dr. Mamta from Vimsar Birla. So I want to ask about medical board. So is there any availability of medical board in every state like in our Vimsar also, or we have to send to SCB Kotak for medical board?
That how many state is there? They from NHM, from government, we have to inquire. Foxy will be sending the link. How many boards are there? Okay. I am not sure, but if it is not there, it is the state government's duty, responsibility to form the medical board very quickly.
Okay.
Sorry to interrupt. All the participants, any queries, please leave in the chat box. We will discuss the queries after the talk session. I would like to request our chairperson, Kirtirekha Mahapatra madam, to give any concluding remarks on the talk so that we can move ahead with the next talk.
Thank you, Sasmita, for such nice, elaborating talk. Very clear, taking out the important differences between the previous one and this one and the advantages. This is very clear, I think. So, thank you all. And
thank you, ma'am.
Especially for making it so simple and so interesting.
Thank you, Sasmita madam. Thank you, Kirti madam. Now we will go for our next talk of safe abortion updates in technology. I would like to request our chairperson, Dr. Richa Sharma madam, Foxy MTP committee chairperson for 2021 to 23, to please chair the session, and please introduce our next speaker, Dr. Mansi Patnaik madam, professor and unit head OBGY KIMS Hospital, for the next session.
Thank you. So now I invite Dr. Mansi Patnaik, and she is already introduced. She is the professor at KIMS Bhubaneswar, and she'll be speaking about safe abortion updates in technology. So Dr. Mansi, we welcome you.
Give me a second. Slideshow. Easy. Are my slides visible?
Yes.
Yes, ma'am.
Okay. Thank you, Dr. Richa. I'll be moving ahead in this respectful abortion care, which is a joint venture of WHO and Foxy. And my topic will be updates in technology. And this is for the safe abortion that we are all here to listen about. So I'll be talking on the existing guidelines, the pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. These are some of the publications of WHO which have come out in over the years. They are on safe abortion, the technical and policy guidance, and medical management of abortion, and others. So these are all available online. Anybody interested can look them up. And they started from 2012 to 2019. These are the publications which is all available to everybody online. And as Dr. Sasmita talked about the historic change that has happened in the MTP rules, and they've changed from 24th September 2021, where it's become a law. So she has updated us about the MTP new rules now. And I'll move ahead in that, and my topic will be about the guidelines of abortion safety. Can you hear me?
Yes, you are audible. Yeah, please go ahead.
So I'll be talking about when we talk of management, it starts from pre-abortion care, and aftercare. So previously we only talked about abortion, but now we start from pre-abortion care. And that is when the patient comes to you for the first visit. So you take a complete medical history, do a physical examination, which means an internal examination also. And after that, you do the laboratory investigations only if they are necessary. It's not mandatory that every patient who comes in goes for a battery of investigations. Only where you feel it's necessary, then it should be done. Just a second. How do I move this? Minimize. Okay. Okay, then even at the first visit, do take a time to discuss the contraceptive options available to her so that she is aware that she should be able to take some contraceptive. If we go on telling them about it, then it is always acceptable to them. And then the decision making is always left to the woman so that she chooses a method of abortion also. She has a chance to make a choice of the method of abortion. So options are given to her with all the side effects or whatever problems can happen with each method so that she makes a informed decision about which method she is going to choose. Then this is the pre-abortion assessment and counseling. So as I said, you take a detailed history, you go for a pelvic examination, general and pelvic examination, laboratory and other investigations. When medical disorders mandate whatever is necessary, you go for that. And then decision-making information on abortion procedures and the counseling part. So how do you determine the size of the uterus or which procedure will be applicable for her? By doing a calculation from her LMP, you judge the period of gestation that she is on the day she has come. So always remember this date that she gives you may not be correct. So PV examination to corroborate the POG or the period of gestation is very important. And if she has not, if it's early pregnancy and she is not confirmed with a pregnancy test, it should be done at this visit. And so when the size is smaller than that expected from the period of gestation, it can be due to either she's not pregnant or it can be an incorrect dating, or of course, keep in mind that it can be ectopic pregnancy or maybe a missed abortion. But when the size is more than the period of gestation, then it can again be a wrong date, or it can be multiple gestation, or it can be associated with a fibroids or any other problem in the any other abnormality in the pelvis, which is increasing the size, or it could be a molar pregnancy. Now, what are the pre-abortion investigations? Remember, routine lab tests are not mandatory for abortion services. But if a pregnancy test is needed, it should be done. Hemoglobin, if you suspect she is anemic, then a hemoglobin estimation. And blood grouping and rhesus testing is necessary if she is a RH, if the RH negative or positive report is not available with her. Take this opportunity to do a HIV testing and counseling about HIV if you feel it is needed. And STI screening usually performed during the pelvic examination. No separate tests are required for this. Other laboratory tests according to her medical history, if it is required, a kidney or a liver function test or other tests can also be asked for. But do remember that ultrasound is not mandatory to diagnose pregnancy, or if you, only it should be done if you are suspecting an ectopic or a missed abortion. So pre-abortion counseling. When we talk of counseling, always ask her about why she came in, reason for terminating the pregnancy, and what is her thoughts about terminating the pregnancy. She should be very clear about, she should not be under any pressure to be doing the MTP. So unless you talk with her, you will not be able to know this. And she should have information about the pregnancy, whether that the early abortion is safe, and it is important to get the abortion at a proper facility, or the provider should be performing the abortion with all the procedures for her safety. And what are the available methods? She should be aware of that. And what are the warning signs that after she, if it's a medical method or if it's a suction and any problem that happens afterwards, she should know of the complication so that she reaches the facility as soon as possible. Without contraception, she can get pregnant as soon as 14 days after an abortion is an information that she should be aware of. Then resumption of her normal activities, including sexual intercourse, should be advised to her. And any other follow-up care with regard to her medical condition should also be told to her. And for documentation, informed written consent is necessary. But decision on post-abortion contraceptive is left to her. But we counsel her about the options that are available to her. But if she is not willing to accept a contraception, abortion services should not be withheld from her. Now, what about clinical management of abortion? As per the global recommendations, we have a slight difference with the Government of India recommendation. As per global recommendation, less than 12 weeks, it's mifepristone and misoprostol, or misoprostol only, or vacuum aspiration. In the Government of India recommendation, we have medical methods up to 9 weeks. There's a small mistake here, where up to 7 weeks, we use the differences in the dose of misoprostol, which is 400 for less than 7 weeks, or up to 7 weeks, and from 7 to 9 weeks, it's 800 misoprostol. I'll come to that again. Now, for 12 weeks, more than 12 weeks, it's mifepristone and misoprostol, or misoprostol only, and dilatation and evacuation can also be done. But what is not recommended is dilatation and sharp curettage. So always remember this: the sharp curette should not be used in these procedures. Then methods of first trimester abortion, you know, it's the MMA, or it can be the surgical methods, that's the MVA or the EVA. Again, when we talk of MMA, we talk of mifepristone and misoprostol. Now, mifepristone, as you all know, is an antiprogestin, and it interferes with the continuation of pregnancy. So once mifepristone is given, it also primes the uterus for the action of misoprostol, which is a prostaglandin analog. Misoprostol causes cervical softening, uterine contraction, and expulsion of the products of conception. So, in this protocols, what are the protocols for mifepristone and misoprostol? On day 1, 200 mg of mifepristone is given orally, and along with that, if she is Rh negative, the anti-D 50 microgram is given. But in most places, if 50 microgram is not available, you can give the 300 microgram that's usually available. On the day 3 is, this is mistakenly written as mifepristone, this is misoprostol. So up to 7 weeks, you have 400 microgram of misoprostol, 2 tablets of 200 microgram each, which can be given by any route, either by sublingual, buccal, vaginal, oral, or for 7 to 9 weeks, it's 800 microgram. In addition, do not forget to give analgesic so that she is comfortable during this period. And if she has vomiting or something, so antiemetics can also be offered to her. But whenever you're prescribing anything, do not forget to mention that contraception, which she will be using after this. And at day 15 is the follow-up day, where you confirm and ensure that the procedure is complete. And again, offer contraception if not already offered, or if she is not accepted, you can re-counsel her again at this time. Now, what are the routes, the different routes for administration of misoprostol? You have oral, buccal, sublingual, and vaginal. The difference in these routes is with the side effects and the onset of action. The fastest is the sublingual route, but obviously when it is very quick, you also have a lot of more side effects like fever, chills, diarrhea, vomiting, as compared to the vaginal route. Now, vaginal route has the least side effects. And of course, the pill fragments may be visible, but this method is the one that is commonly used. But if they are not comfortable with that, you can go for the buccal or the sublingual one. And this is a picture of the buccal, where it is the tablets are put in between the molar and the molar teeth and the cheek. And sublingual is below the tongue that you will be keeping the misoprostol tablets. Then this is the WHO recommendation regimens, dose schedule, and medical abortion. It's less than 12 weeks. They say it is 200 milligram per oral and 800 microgram, again, whichever route can be given. And misoprostol only regimen is also there, where you can give misoprostol 800 by whichever route is suitable to her. But while giving this, always explain to the lady that she may have vaginal bleeding for 2 weeks, which is normal after medical abortion, and sludge bleeding can sometimes rarely last up to 45 days. But when it's continuing beyond 15 days, it needs to be seen. And what are the provisions of MMA services? Services should be available in the primary healthcare system. And this is how the MTP rules have been changed so that it is easier and available at all the primary levels and with referral system. So if any higher care is required, referral system should be in place. Additional services that can be provided along with are counseling and testing for STIs and abuse support services, psychological or social services, and other specialist health and medical services. This is an opportunity to provide all these services at the healthcare center. And if she's anemic, iron tablets can also be given to her. For pain, previously people were not giving much importance to this, but if it is pain management is given, then she should be made comfortable by giving some medications for pain. And of course, emotional support has to be given. A routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services and emotional support and address any other problem that she has had. A routine follow-up is not recommended unless she is using the only misoprostol procedures. To follow up care, assess women's recovery and ask for any signs and symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. And a focused pelvic examination should be done for any complaints that she has. And her assess of fertility goals and need for contraceptive services, if not provided, and it should be reinforced at the follow-up visit. Then coming to the MMA summary. So what is to be done? On the first day that she comes to you, that physical and pelvic examination should be done, confirmation of eligibility for the procedure, and tablet mifepristone 200 milligram given orally after the forms have been filled up, and offer anti-D of 50 microgram to Rh negative women, and tell the woman to return for misoprostol administration after 2 days. The contact address and phone number of the facility center where she should go in case of an emergency should also be given to her. And this, her experience and side effects should also be noted. Now, do remember that 3% of women may completely expel with mifepristone alone, but that does not mean you will not give the misoprostol. So the schedule has to be completed. Give on the second day when that is day 3 when she comes, second visit, give misoprostol 400 sublingually, buccal or vaginal route, and observe for 4 hours in the hospital. And you can give her analgesic like ibuprofen 400 at this time. Contraceptive options are again offered to her at this time. Then usually the mean period of bleeding is 8 to 13 days. And the possible side effects that can happen is like nausea, vomiting, diarrhea, fever can happen. And if there is excessive bleeding, she should come back and report to us. And if there is no bleeding with 24 hours, then consider giving an additional dose of misoprostol. 75% of women abort within 4 to 6 hours after the misoprostol administration. Now for the third visit, that is day 15, pelvic examination to be done to ensure that the process is complete. Again, contraceptive options, hormonal methods, condoms, IUCD, sterilization after 1 menstrual cycle if she's interested for that. Then we have to tell her that she will immediately return to fertility, so she needs to use a contraceptive method. And if 6 weeks have passed and she does not get her periods, then she should also report back. Now, ultrasound only if examination does not confirm that the procedure is complete. That is the only reason you'll do an ultrasound. So what can be the side effects and complications? Now, pain, when we talk of respectable abortion care, we should be non-judgmental in our communication and treat her with respect And part of that is a verbal support for her, adequate counseling, and be a support person to her, and pain management. So ibuprofen 400 has been found to be very good in management of the pain. A persistent pain with failure to respond to these drugs needs an evaluation, such as ectopic pregnancy, infection, or an incomplete abortion. Nausea, vomiting, diarrhea, these are all self-limiting and they need only reassurance. If you find there is infection, antibiotics needs to be started. Now, what happens when there is failure or there is incomplete due to MMA, incomplete abortion due to MMA? So when you call it as failure, you can either offer them vacuum aspiration, or if she is patient and would like to repeat, then you can repeat the MMA. But if there is heavy bleeding and it does not resolve after she comes into the hospital, then it is better to go for a surgical method and do the evacuation. Or else misoprostol can be repeated and then wait for some hour. But still, if bleeding continues, it is better to go for a surgical method. Now, again, for women who present with excessive bleeding, again, how do you judge the excessive bleeding? We say if it's 2 pads in 1 hour for more than 2 hours. If this bleeding decreases over time, then she can go home and routine care is followed up. If this bleeding does not stop, then watch her vital signs and do a PV examination. If you find that the products of conception are there in the cervix and can be removed digitally, it is done. And after that, if bleeding stops, then you don't need to go do any further tests or continue. She can just be observed for some time and then sent home. But if the bleeding continues, the ultrasound is mandated at this stage. And if there are only small bits, then you can just wait and watch. But if a POC and decidual bits are found, then if she's stable, you can give misoprostol. But if she is not stable, then you can go for a vacuum aspiration. And if there is continuation of pregnancy and ultrasound indicates that pregnancy is continuing, then you can go for a vacuum aspiration. So recording and reporting of MMA is also as important as any surgical procedure. It comes under the Mtp Act, so documentation is similar to the vacuum aspiration procedure and is mandatory. The Form C is the consent form, Form 1 is the RMP opinion, Form 2 is the monthly reporting form to be sent to the district authorities, and Form 3 is the admission register for case records. Now coming to the surgical methods of abortion. This is vacuum aspiration, is recommended technique for surgical abortion up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. That is something one has to remember. Now, Mva Methods is again, this is the manual method, and there is a syringe by the company iPass. And here the cannulas used are according to the weeks of gestation, that is 8 mm for 8 weeks and 10 mm for 10 weeks. And this is the electric aspiration. All of us must have used this machine at some stage or the other. And so you're all aware of this. And then so cervical priming, is it needed? So recommended methods of cervical preparation is before surgical abortion in first trimester is oral mifepristone alone. That is 24 to 48 hours before the procedure, or misoprostol 400 microgram given sublingually 2 to 3 hours prior to the procedure. Or you can also give misoprostol vaginally 3 hours prior to the procedure. Now, laminaria tent, which is not much used nowadays with the advent of misoprostol, can also be used, but it has to be given 6 to 24 hours prior to the procedure. Then pain management for vacuum aspiration. Important component of pain management is non-pharmacological and pharmacological. As important as the pharmacological is also the non-pharmacological methods, that is providing a psychological support, explaining each step to the woman in advance so that she knows what to expect, and doing the procedure gently and smoothly, and encouraging the women to relax and breathe deeply. And pain management with drugs, the anxiolytics can be used, diazepam can be given, or sometimes if she is very nervous and she can opt for a general anesthesia also. For cervical dilatation, a local lignocaine 1% preparation can be used. And this does help when you are doing the cervical dilatation. Then NSAIDs like ibuprofen 400 to 800 milligram 1 hour prior to the procedure has also been effective. And for uterine cramping, you can also give ibuprofen 400 to 800 milligram 1 hour prior to the procedure. But these are the small side effects which have to be kept in mind when you are using these drugs. Disorientation, dizziness, and rare case of seizures with lignocaine can occur. Now coming to the steps of NVA. This is a very good method for evacuating in the early weeks, and those who have used it would not like to go to the electric machine back, but always ensure pain control and ask the woman to empty her bladder before the procedure. This is the syringe. By pulling on this piston, you create a negative pressure inside, and then you attach it to the cannula, which is put into the uterus, go up to the fundus and then withdraw it and then attach the cannula. And as you open the lock over there, the negative pressure is transmitted to the uterus. And then it sucks out the contents of the uterus, and by rotating the cannula in a from 10 o'clock to 2 o'clock position with a gentle motion, you are able to evacuate the uterus. Now, how do you know that the uterus is empty? Red or pink foam without the tissue passing through the cannula, a gritty sensation, and cervix gripping over the cannula, uterus contracting around the cannula, and increased uterine cramping. But don't forget to inspect the tissue. It is very important that at the end of the procedure, you inspect the tissue. And concurrent, if she wants the sterilization or IUCD insertion, it should be provided after you have checked the tissues and found that it is complete. And the processing of the instrument is also very easy. You can prepare a 0.5% chlorine solution and put the instruments in it for 10 minutes. That is enough to clean the tissues and also the instruments. Now, what is the post-procedure care? Monitor her for complications and provide management as and when needed. She may leave the facility when she feels okay and after she meets the criteria for discharge, but ensure that she has the information that if any problem, she should be able to reach the facility again, and the medications that she has been given. Now, document all outcomes of the treatment, including any adverse events in the facility register and client's report card. So what is aftercare? Again, it does not end there. Management of abortion complications is also a part of the abortion. So it is, if she has no complications, it's good. But if she does have, then we should treat her gently at that moment and also take care of any complication that arises at this period. So provision of contraceptive information is also important, and offering her contraceptive counseling and the methods available to her. Assessment of any other sexual and reproductive health needs that may require additional care should also be done at this time. Then follow-up, again, no routine follow-up unless miso-alone regimen has been used. To summarize, India has made historic progress in improving access to safe abortion. Nothing much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality and provide a respectful abortion services. Every client is an opportunity to inform, educate, and equip with proper information on contraceptive and counseling. Sorry, did I miss out some slides? Okay. Okay, thank you for a patient hearing.
Thank you, Dr. Mansi. You have wonderfully covered the topic, various methodologies and follow-up counseling part and everything. So the take-home message basically is that the mandatory investigation for before doing MTP is just 3, that is a HB, urine and blood group. An ultrasound, it is not mandatory, but it is desirable only if there is a discrepancy between your history and clinical examination. And if at all you suspect ectopic pregnancy, and also now in the cases of cesareans also, if you are suspecting a cesarean scar pregnancy. So that is the only thing.
Yes.
So now we are running short of time, I think.
Yes.
So we quickly move on to our next topic. So
Yes,
Dr. Yeah.
Next topic is on safe abortion values, evidence, respect, and rights. And it's by Dr. Ajit Kumar Naik. I would like Madam to introduce him to give his next talk. He's an associate professor in SCV Medical College.
Dr. Ajit Kumar Naik, the associate professor in SCV Medical College, Kotak, is Vice President, SFM Odisha Chapter, the Joint Secretary, AOGO Odisha, Chief Coordinator of Urogyne Workshop in AICOG 18, the Associate Editor of SAR Journal of Medical Case Report and Urogyne Manual, the Reviewer of International Journal of Clinical Obstetrics and Gynecology. To his credit, there are so many research publications. And above all, he is a very good teacher and he will be keeping you engaged next 20 to 30 minutes. His topic, he is covering two topics. One is shape abortion values, evidences, rights and respect. And another is pre and post abortion family planning counseling. Both the topics are very important. Dr. Ajit, please. You are muted, Ajit.
Okay. Good afternoon, everybody. Thanks, Professor Dr. Kirtireka Mahapatra and Dr. Richa Sharma for the kind words. I am assigned to talk on family planning counseling, that is before abortion and after abortion. And so as we know, counseling is a structured interaction in which a person voluntarily receives
Slide move kar.
emotional support.
Slide share.
Slide share है नहीं, कर दो.
Yes.
Is it visible now, madam?
Yes.
But not slide share.
Slide share kar.
Slides.
Click on the share screen button. After that, you select the screen.
Slides.
So regarding counseling, I think it is visible and audible.
Yes.
Show him.
So counseling is a structured interaction which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions.
Only slide show thibo kar diyo. Slide show.
Okay.
Sir, Ajit sir. Hello. After clicking the share screen button, please select the screen. Please click on share screen. After that, select screen.
देखा हो तो ठीक से
Slide show.
स्लाइड शो करू ना एटी अच्छी स्लाइड्स
तले right hand side रे थिबो.
क्या न जानी न अनल सेम देखा हो कौन करियो गोटे गोटे क्लिक करो
तले right side रे गोटे थिबो slide show कर. Full screen करिया को गोटे थिबो.
Yes, you can continue. There is some problem. It is visible. We can continue.
अजित कोई भी असेन देखा हो अजित you start it is visible
So these are the pre-procedure counseling. That's a very critical role. So first is help the woman to decide about termination of pregnancy. Again, help to women to choose the correct method for termination. Ensure delivery of complete information about the procedure, already highlighted by Madam. Help women to adopt a contraceptive method. That's most important after the abortion care. So these are the pre-procedure counseling. Ensure privacy and confidentiality, that is most important. And always be non-judgmental and be sensitive to the woman. And you have to establish a good rapport with the client. Use simple language and allow the woman to clarify her doubts. If she has made up her mind for termination of her pregnancy, we have to assess her for the procedure, which procedure will be appropriate for her, whether it is a medical method or it is a surgical method, that we have to help her. Now, these are the relevance of peri-abortion family planning counseling. So, why it is important? Because there is a quick return of fertility, that is, ovulation may occur within 14 days of termination of pregnancy. And here we get an opportunity time so that patient will be very much in contact with us. So they will have attention to receive our contraceptive advice, and acceptance rate is very high during this period. And we should tell there is a healthy spacing of pregnancy. So minimum 6 months of gap is to be kept before next pregnancy. And we should tell the health benefits and better future pregnancy outcomes of the modern contraceptive methods. So pre-abortion family planning counseling, when to start? This thing has to be started at the time of very first visit or once we are consulting the patient. And the exception is grief management. So what are the things to counsel? That the return of fertility is 10 days to 4 weeks. So as early as 10 days, she may ovulate, and we should help to choice so that we can help them to choose their contraception methods, and we should do method specific counseling. That's most important. And we should find out any high risk behavior among themselves so that we can advise for barrier method of contraception. Most important thing is that if the woman is not willing for any contraceptive method, we should not refuse MTP. Try and counsel her after the procedure. If she is still not willing, we have to call her for follow-up in a week's time and counsel. So contraception counseling is very important, and we should try the patient should adopt any of the contraceptive method among the cafeteria choice. So these are the assessing suitability for post-abortion contraception. Abortion process should be complete, and there should not be any existing infection. There should not be any injury to the genital organs, and chances of fresh pregnancy has to be ruled out before adopting any new contraceptive methods. And coming to the post-procedure counseling, the critical role is ensure the woman has understood the precautions and care needed during the post-abortion period, like we give advice and care to the postpartum woman. So opportunity to counsel for contraception in case not previously accepted any contraceptive method, and reinforces the need for continuing use of contraception method what already chosen by her. The post-procedure counseling, so continue to ensure privacy and confidentiality. That is the most important aspect of the RAC. You have to reassure her in case of any problem arising. Repeat the information about the post-procedure care and the danger signs which may occur out of the abortion procedures. These are the post-abortion family planning counseling. If somebody has already opted the counseling, we should appreciate her, and we should give immediate care. Either we can give an intrauterine contraceptive device or medroxyprogesterone acetate. We can give oral pills, and we should have a follow-up protocol if somebody has adopted any contraceptive methods. And continuity is most important. Uninterrupted continuous supply is also very important, and cards has to be maintained. If somebody has not decided about the family planning counseling methods, we should allay any anxiety within her, and we should tell her what are the importance of immediate adoption of contraception and choosing a good method. We should extend period of adoption, and the couple has to be counseled, not only the women, but also the husband. And we should insist on the emergency contraceptive pills to avoid any unwanted or untoward pregnancy in future. These are the post-abortion contraceptive methods. Number one is barrier method. As we know, we can use either in the first trimester or the second trimester abortion cases as soon as sexual activity is resumed. As we know, it has no hormonal side effects, can be used without consulting a health provider. It's easily available. Most important part, it helps in preventing STIs and HIV infections and enable men to take responsibility of contraception. Then most important is intrauterine contraceptive device, what we are using IUCD 380A for 10 years and 375 for 5 years. It can be given immediately, or it can be given up to 12 days after the confirmation of completed abortion. But with MMA, it should be inserted around day 15 of the process, or if we are sure there is no chance of infection, otherwise there is a chance of expulsion is high. In second trimester abortion cases, it can be inserted immediately, or it can be inserted up to 12 days of the procedure, and unless there is any contraindications. As we know, it is a very highly effective method, provides very long-term contraceptions. It can be provided by the MBBS doctors, nurses, ANMs. And for second trimester cases or abortion following medical methods, the PPI-UCD trained doctors ideal candidate or service provider for IUCD insertions. It does not interfere with sex, immediate return to fertility once it is removed. Of course, it has no hormonal side effects. The post-abortion contraceptive methods, coming to the oral contraceptive pill, it can be started immediately after the abortion or up to 7 days after abortion using surgical method. If we are using medical method of termination, it can be started on day 3 along with the misoprostol dose. If not given, then it can be started within 15 days of the process after confirmation of the completion of abortion. In case of second trimester MTP, it is started immediately or it can be started within 7 days after the completion of the abortion process. As we know, it regulates the menstrual cycles, can be provided by a health workers after initial screening. It does not interfere with sexual life, offer protection against ectopic pregnancy, against endometrial and ovarian cancers, and benign diseases of the breast like fibrocystic breast diseases and fibroadenomasis of the breast. It is not suitable for women who are breastfeeding babies of less than 6 months old. Coming to the long-term injectables, as we know, medroxyprogesterone acetate, it can be started immediately or up to 7 days after first trimester abortion. And if we are adopting MMA, it can be started on day 3 with dose of oral misoprostol. If you are doing a second trimester MTP, then it can also be immediately started or it can be started within 7 days after the abortion. We know it is highly effective. Confidentiality and privacy is very much maintained. It can be provided by any service providers, does not interfere with sexual life, does not affect the quality and quantity of the breast milk. So it is a very good thing for lactating women. No estrogenic side effects. It offers protection against ectopic pregnancy, ovarian malignancies, iron deficiency anemia, and also it helps in reducing the uterine fibroid size. Coming to the permanent methods, female sterilization is a very common operation. So it can be performed after the first trimester MTP. And it can be done if there is no infection or there is no ongoing blood loss. It can be done concurrently at the same sitting of the abortion, or it can be done up to 7 days. Both mini-lap and laparoscopic sterilization can be done. If somebody is adopting medical method in first trimester MTP, it can be done only after the first menstrual cycle. That's important. And if you are doing a second trimester MTP, mini-lap sterilization can be performed at the same sitting, or it can be done up to 7 days after an abortion, unless there is any presence of infection or severe blood loss. We should note that in second trimester MTP, laparoscopic sterilization is not recommended. Only mini-lap sterilization. As we know, the advantages are many. It is a very permanent method. It's very highly effective. Coral index is very low, very less than 1. Its effect immediately, no interference with sexual life, does not affect the breastfeeding. It has no long-term side effects. It offers protection against ovarian cancer. Coming to the male permanent methods is vasectomy. And you know, it is independent of timing and procedure of the abortion. It's very effective. It is a permanent method, does not interfere with sex. Long-term health, this couple must use another contraceptive method for at least 3 weeks after conducting the vasectomy operation. So these are the contraceptive methods. When to start in medical method of abortion cases, combined pill has to be started on day 3 when the patient is taking after the abortion, or it can be started after 15 days. Injectable methods can be started any day after day 3 of the abortion process. IUCD, it is started 15 days, and tubal ligation can be done concurrently. Sorry, it can be done after the first menstrual period. Now, if somebody has MTP with vacuum aspirations, the combined oral contraceptive pill, it can be started within 7 days of the procedures. Injectable contraception like DMP can be given again within 7 days of the procedure. Intrauterine contraceptive device, it can be given up to 12 days of the completion of the procedure. And tubal ligation can be done either in the same sitting or it can be done within 7 days of the MTP procedure. These are the SRA services, that is teleconsultation and other technologies which is available. These are the leveraging technology service provisions. As we know, in the COVID era, everything is tele. So teleconsultation, telecounseling, teleguidance, telereference, telelinkage, and website. We know we can use the YouTube, infographics. These are the various helplines and education platforms like WHO, Ministry of Health and Family Welfare, RCOG. And this is the strength, weakness, opportunity, threat, teleconsultations. Strength of teleconsultation is increased because of the COVID era, because of the awareness, and weakness. The problem with the teleconsultation is that there is no face-to-face communication. There is no facility to demonstrate any procedure, and the opportunity is very important. Cost saving, number of visits also cut down to the hospital. Privacy is restored, comfort is restored. The threat is missed opportunity, and sometimes misdiagnosis is there. Now, applicability of components of the comprehensive abortion care. CSE means comprehensive abortion care. Assessment is most important. Then we have to confirm the diagnosis. Then after the abortion, we should help her regarding the contraceptive methods, and counseling can be done by the Zoom or video conferences. Any procedure, after any family planning procedures, follow-up is most important, and that can be done either in the online or physical, that is hybrid service. So it is one visit for the surgical evacuations, and for MMA, it may have 3 visits. So coming to the key messages, we have to realize the need of post-abortion family planning services, bring the couple on board, and strive for 100% coverage. We have to capitalize on the baskets of choice of contraception, and we should know the applicability in the post-abortion period. Technology, we should use as far as possible. Scope for entry in comprehensive abortion care services. We should concern about the policies, various malpractice, service cost, and accessibility of the procedure. And adolescents' reproductive health needs both offline and online services. So this is the thing about the counseling aspect following abortion. Thank you for patience hearing. Icon ଅଛି କାଉନସିଲ ଏଇଠି ଲୁଚି ଯାଇଛି ତାରି ଉପରେ ଏଇଠି ଲୁଚି ଯାଇଛି ହିୟର ସେଇଠି ତା ଉପରେ ହଁ ଏଇଠି ଲୁଚି ଯାଇଛି ଏଇଠି ହଁ So the next topic is so severe approach, that is that is safe abortion, values, evidence, rights, respect. That is called severe, and it is very important component of respectful abortion care by joint venture of FOXI and WHO, Ministry of Health and Family Welfare, Government of India. This module aims to define what is a respectful abortion care as per WHO, highlights how norms and stigma affect the services, provide WHO several resources for respectful abortion care. So momentum has been created law has changed, already told by Sasmita madam. So dissemination needs association and obstetric gynec provide support. Foxy, as we know, is the largest provider base for abortion care. Online training is possible due to the COVID, and here we can take the opportunity to provide online service for respectful abortion care to all providers, and medical method of abortion uptake is increased. As we know, it can be done in a very early pregnancy. It is relatively safe, and it ensures no PCPNDT conflation. Patient safety, respect, quality matters more than ever, and we all have a role to play. So what is respectful abortion care? It's adopted from WHO. It refers to care that maintains safety, dignity, confidentiality. It ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. So it is, in simpler term, it is a respectful care, and the concept came after respectful maternity care. So as a provider or as a patient, treat or treated, it should be with dignity, empathy, compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancy, miscarriage, or abortion. If you ever feel that something is not right, speak up. As health professional, it is our duty to listen and support, for which the communication skill is the key for respectful abortion care. So what are norms and stigma? Stigma and norms perpetuate disrespect and abuse. So as we know, these are the disrespect and abuse, physical abuse, verbal abuse, sexual abuse, discrimination, failure to meet professional standards of care, poor rapport between women and the service providers, health system conditions where we are working, and the constraints. These are the right of every woman: freedom from harm, freedom from ill treatment, right to information, protection under laws like Mtp and POXO Act, informed consent, refusal, respect for choices and preferences, dignity and quality of care, right to timely health care, and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion, that is undue influence. These are the domains of respectful abortion care. This is more important. 12 domains of respectful abortion care, and these are adapted from respectful maternity care. So free from harm and confidentiality, privacy. You have to preserve the woman's dignity, respecting woman's choice, engaging with effective communication, that is soft skill is most important, informed consent, and ensure there should be a continuous access to support what we are providing. We have to enhance the quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, continuity of care, and post-abortion counseling. These are the time to strengthen the implementation. So as already discussed by Dr. Sasmita Swain, up to 20 weeks, 1 RMP, after 20 to 24 weeks, 2 RMP, and beyond 24 weeks, it is the need of the medical board, which has to be constituted under the banner of the FOXI in many centers where the abortion care is provided. So one provider responsibility is more, starts from counseling, starts from giving contraceptions, referral, and most important is the compassionate care. And 20 to 24 weeks for special cases, we need sensitivity and judgment-free and timely service, because if we don't terminate within 24 weeks, then we have to take the help of the medical board, and the indication for termination of pregnancy also has to be changed, like lethal congenital malformations. So guide to avoiding stigmatizing language. This is the WHO training for safe abortion values, evidence, and right. That is called SAVER Toolkit. So self-spaced games. From 1970, we know there was unsafe abortion. In 2000, the concept of safe abortion came. And now in the era of 2020, it is the respectful abortion care. Now these are the questionnaires. If everybody allows or permit, I can discuss the questions. If chairperson permits me, I will discuss the questionnaires, madam.
Was it in the module, Ajit?
Yes, madam. It is there in the SAVER kit.
How many questions are there?
It is around, madam, 1, 2, 3, 4, 5, 6, 7.
Sasmita, it will be okay?
Yes. Just
No, I
quickly.
think there are only 3 questions. Maybe 5
Okay, sir.
slides.
No problem. If everybody permits me, then only I will discuss the question. Otherwise, you can omit it, no problem, because it is just everybody knows these things.
No, you'll be actually surprised, Ajit, how many people actually know it. We have
Yes,
done this in
yes.
17 workshops so far.
It's a long list.
Okay, continue.
So according to the World Health Organization, restricting access reduces the number of unsafe abortions. These were the questions. So what should be the answer? It is true or false?
Please,
The
colleagues,
answer
put it in
is
the chat box.
false.
False, false.
It is false.
Yes. Now the next question is the Mtp Amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. What should be the
Before you
answer?
show the
True or
answer,
false?
before you show the answer, can we have some people putting in the chat box? Is it true or false? Can we have some responses? Is the statement true or false? Okay, so we have 2 truths, 3 truths, 1 false, 4 truths, 5 truths, 1 false, 6 truths, 1 false, 2
Shall I
false,
tell the
7
answer,
truths.
sir?
Yeah, okay, now you can show the answer.
So this is the answer.
See, this is what we are trying to emphasize, that we may think that is the correct answer, but actually it is false. And the reason for that is also shown there. Yeah, carry on, sorry.
30-year-old woman recently widowed wants to get an abortion at 22 weeks as a service provider. It is our responsibility to tell her to continue this pregnancy. Yes or no? After the new amendment, I think answer will be.
Yes,
Answer
yes.
should be.
No, we can do it.
We should do it.
Okay. We should
Yes,
do it.
she belongs to the vulnerable group. If she wants,
Yes.
you have to do it.
Madam, what is the answer? Yes or no?
Yes, yes.
No, no, no. It is not
No,
our
no, no,
responsibility.
no.
No.
She can abort.
Answer is no. Answer
Yes,
is
no.
no.
Thank you, madam. Answer is no.
She belongs to
Answer
the
is no.
vulnerable
She
group.
can go for MTP.
And the answer is no because of the new rule, new amendment. Thank you.
Thank you, Ajit. You have nicely addressed both the topics. As you have already discussed the same word, that is the respectful abortion care. It is more important. Along with safety, we should respect the woman and we should never be judgmental. And this contraception that should start from the contraception counseling should start from the beginning of the procedure. But if the patient doesn't want to take the contraception, you cannot deny MTP. That one should work. Even if she doesn't want any contraception, you can counsel about the pregnancy risk as well as emergency contraception. And even if she wants contraception, you should not be judgmental. You should give her a cafeteria approach. All types of contraception she can use. Then she has to make a choice. You should not choose for her. She should choose. That is the message. Nicely. Thank you, Ajit, for that.
Can you just discuss that question of less than 18 years and with the consent of the guardian and parents?
Madam, actually, both parents not required, only one will be sufficient.
Only one parent is required. Okay.
Yes,
Okay.
yes.
Okay.
But parent or guardian is required.
Madam, the question is little bit confusing.
Hello, it's not even parent.
Not
Any
even
caretaker. Any
Yes.
caretaker can do it.
Yes,
Guardian
yes.
is sufficient, not both.
Any guardian, any guardian, no, any guardian, he is more than 18
Above
years
18
and
years.
and is agreed to take the responsibility can be the
That's the
person. Yes.
Okay.
It need not be her parents. So law has
They
been
will be
liberalized
guardian.
so that they will not feel shy to come, because for that they are going for unsafe abortion and increasing the morbidity and mortality. For that, law has become very liberal in allowing them to go for abortion. But POSCO has to be maintained. We may have to inform the police if she is a minor.
Yeah, in fact, I fully agree with you, Sasmita, because POSCO and what has to be provided as a service are two different aspects. If it falls within the POSCO purview, it needs to follow the route of POSCO. However, the services still should not be denied by taking a consent or taking, the authoritative consent of an adult who is present there. You may decide to check the validity of the age through any of the means of Aadhaar card or something, and which you can retain with you if you like to, so that you as a colleague, as a service provider, is protected and safety first for yourself as well.
Ajay, this is Dr. Rajal.
Yeah.
Aadhaar card, yesterday we had one patient whose age as per Aadhaar card is 13 years and she doesn't look like 13. So we have now asked for the radiology department for her age estimation. She is married and she has delivered yesterday. So maybe sometimes that Aadhaar card age is also wrong. So we need to go for the ultrasound, the radiological help. But in that also they give a range of 15 to 18 or 16 to 18. So that time it becomes difficult for us.
Yeah, no,
it's
I
a
fully
tricky
agree
situation.
with you. There are these challenges and several of these which keep coming, and all such cases are exceptional cases, out of the norm. Majority fulfill the norm. These exceptional cases, you need to do whatever due diligence that you have to take care of.
Yeah, and at that time, I think we should take an advice of a medical legal expert so that we can at least, don't come into any problem of the medical legal issues. That's what I feel.
I agree. Absolutely, I agree.
Yeah.
Any other?
So
Sir, I wanted to say hello.
Hello. Sir, all are concerned about the medical board. So,
yeah, that is an absolute gray area right now. In our first discussion with Government of India and WHO, this is the thing that we have been raising, that the medical boards, while the new law has come and all of that has happened, the medical boards are not there, non-existent, or some places they are non-functional. But we need to take cognizance of one important fact, the constitution of such medical boards requires a certain qualification and a certain number of people. With 87% of vacancies available in the country of that requirement, it is going to be a challenge going forward. Having said that, there is an option whereby any such cases can be referred to the medical college and the OBGYN department under the leadership of the HOD. HOD himself or the dean can constitute such a medical board, and that medical board with colleagues as described in the WHO protocol, they can join that medical board and they can very well, give an opinion or a decision on that, and which can be ratified by the court if required, and a procedure or a services can be provided. So it may be a roadblock right now. We are hoping that going forward, because the rule has just come in September 2021, by the time it rolls out and all that happens, I'm sure it will take some time. But in the meantime, already subtle remedial measures are existing, which you have been using it in the past and can continue to do so, because you are within your legal right as a service provider to make sure, you are safe, the woman is safe, and she gets the required services. And what we have also worked out with WHO and GOI with discussions is that as and when Foxy gets such information of formation of medical boards, Foxy will relay that information to all its members wherever it's happening, in whichever states it's happening. So that's another thing that we have tried to see if we can make that possible. I think it's been a wonderful session. If there are no further questions, I hand it over back to the MC and to,
Hello, sir. Hello.
Yeah, Ranjana.
Sir, in CAC training, we teach that HIV training and HbSAg training is test is not needed. It's only blood grouping, RH typing, urine for sugar and albumin, and hemoglobin. Only 3. So should we include HIV and HbSAg investigation in the abortion cases, pre-abortion investigations?
No, it's not required.
I think in surgical cases we have to include, but in MMA we may not include.
But in CAC training we don't.
Also, it's not mandatory. If you're using, you have to treat the instruments in 0.5% chlorine. That is enough. You don't have to go for HIV testing.
It is not
Yeah,
mandatory.
that's what I was thinking. In CAC training also we say it's HIV investigation not needed.
Yes, it's not needed.
Secondly, another thing is in CAC training we say that when MMA method is only up to 7 weeks. Should we say 9 weeks?
9 weeks.
Government of
Because
India.
in CAC training, whatever we are teaching, I am a TOT of CAC training. We teach it's only up to 7 weeks. One tablet mifepristone, 2 tablets misoprostol after 24 hours. On the second visit. But now you are saying that up to 9 weeks also we can give 800 microgram. Should we teach that in CAC training also?
Government of India guideline is up to 9 weeks for MMA.
Yeah.
So should we start teaching CAC training this 9 weeks system, or should we still go with 7 weeks only?
We should go to the 9 weeks since it's a Government of India guideline.
Till 9 weeks, no?
Yes.
Then we can teach up to it's the 9 weeks.
Yeah.
And HIV not needed.
See, what happens is by the time one left arm of the government issues something, by the time information reaches the right arm, there is going to be a lot of time consumption. And by the time all the policies, documentation align, something else changes, So since you're part of this training and it is already mandated by Government of India and WHO, the guidelines are very clear. You can go ahead and follow the same.
Thank you, sir. Thank you. Thanks a lot.
Over to you, Sasmita, or whoever is leading,
Yes,
or
sir.
Barsha.
So
You can
thank
close
you,
the
sir.
session if it's all good with all of you.
Yes,
So
sir.
we have
Thank
come
you. To the end of the session. I really thank you, Ajay sir, for staying throughout the program with us. You are really inspiring for us to do this. And I am also thankful to our president, Dr. Santa Kumari, for giving us the opportunity to conduct this very important and unique training for our society, for which we will be obliged to her. And I also thank so many participants who have patiently stayed with us and went through this training. And special thanks to our Sama Madam, our most senior and most passionate member of our society, who always thinks about the mother of the society, mother. And I really thankful, Madam, for staying with us. And Janmajay sir, Sujit, Sanjay sir, and everybody who are present with us, I am really thanked from my core of my heart because you have joined this training. And I thanks Dr. Richa for joining us as the chairperson MTP committee. And I also thank Kirtireka Madam for being the chairperson. And I thank Ajit and Mansi for being the trainer. And I also thank Barsa, our the main person behind our every technology. We need Barsa. Without her, this webinar will not be possible to manage.
Huge congratulations to everyone. A round of applause for everyone. Very well done. Delighted. Bashir, are you posting the post test here? Bashir? Bashir, can you post the post test here so that people can use the link?
And it was thank to Dr. Razal Thakur for joining our society. Thank you, Razal Madam.
Much. And I was at my college and then I was leaving. So in between I was in traffic. So I have switched off my video in between. But good to see you all and looking forward to meet you soon at the AICOG.
Very nice of you for joining.
Oh,
thank you, ma'am.
It's not responding. Let me put that thing in the chat box. Please click on this to submit your post test. Yeah. And later on, others can also, if you left the meeting, you can also submit it there. Is Shyama still there?
Shyama Madam?
No, I think she's left.
Oh, that's so sad. I would have been seeing her after years. You've been closely working for almost several years now. Oh, it's a pity. Please, whoever meets her, please do remember her.
Okay, I will definitely tell her.
Yeah,
Madam
tell
is
her I
now
was remembering her very fondly. Yeah.
Madam is now in charge of the Center of Excellence at SC Medical College, and she is doing tremendous job. She is connecting all the districts
Very
and
committed
everything.
person. Please remember her, me to her, and please tell her that I have said a huge hello and a big namaste to her.
Okay.
Yeah. Okay. All the very best. Thank you so much. We look forward to having more such sessions as we go forward.
Thank you.
Good evening, Rajan. I'm happy to be part of this training program. So I'm just now filling up my post test. This is Rajal from Ahmedabad.
Yeah, Rajal, I was wondering how you're from Ahmedabad. You've come over here.
No, but I found I found the link in one of the Fox's groups. So I thought this is interesting, and so I had not taken this training. So let me. Yesterday I filled up the form, so I'm good that I could complete it. So I'm just.
So I was wondering, Rajal is working and suddenly Rajal is here. So I was thinking this is another Rajal, your cousin sister or something.
No, this is one and only Rajal Thakur in Foxy, sir.
Sir, many persons also could not join due to the problem with this link. Otherwise, they would have joined.
No problem. You immediately, what I will suggest is Barsha and Sasmita, please arrange another program.
Yes.
Send me, and the protocol to send anything to us is send the date, send the time, what you want, and expected numbers. Okay. Based on that, we'll allocate the Zoom and same process will be followed immediately. Yeah. Okay. So all the very best. Safe travels, Rajal, and each one of you have a lovely evening. Bye-bye.
Thank you, sir. Thank you.
Bye.
Thank you, everybody.
Thank you. Thank you so much.
So thank you, Varsa and everyone.
Thank you, madam. Thank you, Mansi, madam.
Thank you.
Thank you.
Okay. So
हॉस्पिटल रे बसछि
अच्छा मानसी बहुत दिन पर देखी करते